So for the obstetrics, we are going to start with the basic one. Let me tell you what you need to do from here. Basically, the basics one, you can just give it a read. After that, you can start from here, antepartum care, and you have to continue reading all of this one. Then antepartum hemorrhage is very, very important. Obviously, the counseling part is important in the CDM questions, along with some MCQs as well. But the antepartum hemorrhage, like placenta previa and placental abruption, is more important. You can skip vesa previa. Then going to obstetrical complications like labor, rupture of membrane, postpartum pregnancy, intrauterine. So you have to do all of these ones. Then multi-fetal gestational is just, if you can read it, twin to twin transfusion is kind of okay. Then hypertensive complication and the diabetes, both are important in pregnancy. Along with this iron deficiency, early onset, urinary tract infection is important. Infection during pregnancy, yes, you need to know, as you know, the treatment in the pregnancy is kind of different from the usual one. So that's why the infection during pregnancy is important. Then venous thromboembolism, you can just read it. Then normal labor and delivery, more than everything here, the fetal monitoring in the labor is kind of more important. And definitely the basic major steps in the normal delivery. I will let you know what you need to know. Then induction and augmentation of labor, because if the labor is prolonged, what are you going to do? Then all these abnormalities is important, especially the uterine prolapse, uterine rupture, umbilical cord prolapse, and the umbilical fluid embolism. These are important. Chorioamnitis is important as well. Then you can skip these ones. Operative obstetrics, we don't need to know this one. Then coming to complications, you need to know the postpartum hemorrhage, retained placenta inversion. So that's it. You don't need to go into every single detail of it. As I told you, what are the important ones, you have to go through them very thoroughly. But the rest of the topics, if you have time, you can give it a read. If you don't have time, you can just skip those ones. Otherwise, basic knowledge about the rest of the things are, that's it. Coming to the basic anatomy review, you can just skip this one. Coming to here, diagnosis of pregnancy, definitely something about this investigation. So beta HCG, you are going to look into that one and see positive in the serum. When is going to be the serum beta HCG positive? On the 9th day of post-conception. That's it. And we are going to start with this one, ultrasound transvaginal. When is the diagnostic one and when is the next one? So 6 and 8 week intrauterine pregnancy start getting visible. Then transvaginal, when are you going to start? 5th week, 6th week, 6 to 8 week. So on the 6th week, you can see the fetal pole visible. That's it. And the fetal cardiac activity is visible on the 6 to 8 week. That's it. You need to remember only the time when the certain type of things start visible on which week. Establishing the desirability of pregnancy in a patient with a suspected or confirmed pregnancy informs the construction of then inappropriate management plan. Then beta HCG rule of 10S is 10S is basically 10 IU at time at the missed menses. Then is 100,000 and 10 week, and then 10,000 is basically term at IU at term. So just remember the tens of these one if you can remember. Otherwise, it's okay. Then trimester is 1 to 14, then 14 to 28, and 28 to 42 week. Coming to here, the changes, I would say just go to the endocrine changes. That's kind of important. Knowing a bit of hematological changes, those kind of important. So just give it a read. Otherwise, skin, there is pigmentation, linea nigra, proliferation, spiderangiomas, palmarothema, and striae gravidarum. Now, in the skin conditions, as I already told you, need to know the pictures of it. How does they look like? If you see the picture of it, because sometimes they give you there's a female who is coming to you, they can give you a picture of striae gravidarum, right? So they are asking you what you would do next. So if this is a striae gravidarum, you are going to do just reassurance. Then once the pregnancy will resolve, this skin condition will go away. That's it. You don't need to do more about it. But if you don't know how the striae gravidarum look like, you will keep on thinking this might be some certain type of skin condition, and you will write some steroid or something like that. So that's why you need to know how does they look like. Then coming to cardiovascular hyperdynamic circulation, increase cardiac output, blood pressure decreases, and venous output increases venous pressure. Then coming to hematological, what you need to know is basically there is gestational thrombocytopenia, and how much is this platelets? More than 70,000. So that's why you need to know, because if you don't know that platelets less than or more than 70,000 in a pregnancy, you will think that there is a certain type of condition going on. That's why it's important to know the normal. Then hypercoagulable state, and then decrease total protein level and the albumin decrease. Coming to respiratory, what happened is increase O2 consumption, elevated diaphragm because of the anatomy, then increase minute ventilation, decrease lung capacity, and no change in the vital capacity. Coming to gastrointestinal, most importantly, there is a decreased GI motility. So the constipation is kind of okay and kind of normal in the gastrointestinal, as there is an increase intra-abdominal pressure. Coming to gastrointestinal, there is an increased urinary function frequency. So that's why UTI is very, very common and increased in the pregnancy. With a polynephritis, where then glycosuria is kind of normal as well, and then ureteric and then renal pelvic dilation. So these things as in. Coming to neurological, so there is carpal tunnel syndrome, sciatica, and Bell's palsy. That is an increased incident. Coming to endocrine, what you need to know in the thyroid functions. What happened to thyroid? That's important. What happened is increased total thyroxine and the TBG. This is very, very important. I saw many questions from this one. What happened to thyroid? And they give you that the thyroid level or thyroxine level is increased in pregnancy. So what is this? It's kind of normal, because what happened is moderate enlargement happened. So once the pregnancy resolves, it will come back. Then increase total thyroxine and TBGs, normal free thyroxine level. Along with the other one, physiological TSH, adrenal calcium had decreases the amount of maternal calcium. So those ones, just give it a read. Thyroxine or thyroid is more important than anything else. Then coming to the preconception counseling, what are you going to do? So in the 3 to 8 weeks, what are the organogenesis? So it's very important to let the female know about all of those things. Then past medical history, vitamins. What are those certain vitamins? Iron supplements in the T2 and T3 level, T3 trimester. Then increase in the social risks. What are you going to tell? The smoking, alcohol, substance use, domestic violence. Why I'm telling you to do these ones? Because in the CDM question, it's kind of important. They might ask you, what are you going to do the counseling, or a female who is about to get pregnant, what are you do for the counseling? So if you know you are going to tell the person to stop smoking, alcohol, substance use, and if she is facing any domestic violence, or if she is having any occupational risk factors, so you can discuss all of those things. Coming to medications, you can discuss the medications as well. Infection screening, so you are going to do which infection screening you need to do. So this is important, right? Rubella, HBsAg, VDRL, pap smear, gonorrhea, HIV, TB testing on travel and working in the healthcare, history of varicella or vaccination, or the parvovirus immunity if the exposed or to the small children. So that's what you are going to do. Genetic testing as appropriate for the high risk groups. So the infection screening is important. They can ask you what kind of infection screening or which important infection screening you are going to do in the preconceptional counseling for a female. Family physician and the midwives can consider obstetric consultation for conditions including. So if they ask a female who is going to get delivery in the midwives, in which conditions she should take the obstetric consultation. So these are all the conditions. What are those ones? Malpresentation, multiple gestation, Tito lac, then insulin dependent GDP, GDM, antepartum hemorrhage, PTL, preterm labor, PPROM, then failure of the failure of the progress, induction, and then tears in the third or fourth prolapse. They might need to stitch, and then retained placenta, IUG, and postpartum hemorrhage. So in these conditions, they might need the obstetric consultation. So this is important. They can ask you in MCQs and they can ask you in the CDM question. Advise all the patient capable of becoming pregnant to supplement their diet with the 0.4 mg per deciliter of folic acid. What happens is they can prevent the neural tube defects. Then coming to the initial prenatal visits, you are going to start with the first one and second one, third one. So just know the basic one. What are you going to start? So dating ultrasound is done on the, this is it. Dating ultrasound is done or should be offered to all women at 8 to 12 week of the gestational week. So then EDD by the ultrasound is basically after 7 weeks more reliable than LMP. So that's why it's important to do the dating ultrasound, because it's more reliable than doing the LMP or knowing the LMP. Then in the patient, in the history of the previous pregnancy, always say GT-PAL and those things, birth weight, gestational age, or anything that's complicated. Then physical examinations, you are going to do all the BP, weight, these BMI for the patient who is having DVT or GDM. Then investigations, you are going to do all the blood works because this is the first time the patient is coming. So you are going to take all the history thing. So blood work, urine testing, and pelvic exam, including the pap smear to rule out any chlamydia or gonorrhea. So it's important because in the first visit, what are you going to do? Or in the initial visits, what are you going to do? So the basic things you need to know. Then nausea and vomiting, if the patient is presenting, and how are you going to rule out? So first thing first, always start with the counseling, how she needs to eat. So rule out any other cause of the nausea, vomiting. So weight frequency, she might has the assessed level of the dehydration. So test urine for the ketone because she might be experiencing diabetes mellitus. That's why she might be having nausea, vomiting. Having nausea, vomiting is normal, but having more than usual that can present her to come to the emergency with the nausea, vomiting, that's kind of unusual. So that's why you have to do the ketone level or other testing. Even you might need to rule out other diseases that can lead towards the nausea, vomiting, and I will let you know in which condition they are. Non-pharmacological, you are going to start with the frequent small meals, electrolyte like giving Pedialyte. So stop prenatal vitamins like maybe folic acid causing the nausea, vomiting. So that's why you need to know. Increase sleep and rest, ginger, and acupuncture. So first thing first, non-pharmacological. Now, if the she had already tried all of those things and they have I'll mention in the scenario. Now you're going to move on to pharmacological. So in those ones, starting from the pyridoxine. So the first line is vitamin B6. Moving on to any other pharmacological disease, you are going to start with the pyridoxine like the vitamin B6. Then H1 receptor antagonist should be considered for acute and chronic episodes. Then metoclopramide and phenothiazine, you are going to start then ondansetron, and then consider use of acid reducing medications. Then switching on to antacids and H2. So first thing first, pyridoxine, and after that you are going to start with the ondansetron, metoclopramide, or phenothiazine. Then hyperemesis gravidarum, where the patient is not even able to sit down and she keeps on having this vomiting episode. So you have to rule out all of the systemic causes because this is more than usual. So there could be some underlying disease that is going on, and multiple gestation. So these are the most important. Rule out other obstetrical causes. What are those two? Multiple gestation and GTN. So these are very, very important because if the patient is experiencing more episodes of nausea, vomiting, she might have multiple gestation, right? And if not, then she might have GTN. So that's why you need to follow up these two scenarios or these two cases or causes of the nausea, vomiting. So they can ask you the differential diagnosis of hyperemesis gravidarum. And basically, you are going to start with the obstetrical ones, then moving on to the non-obstetrical ones. So the first thing first, multiple gestation is one of the very common thing that can lead towards the hyperemesis gravidarum or the increased episodes of nausea and vomiting. Then GTN, and then other ones, GI, pyelonephritis, thyrotoxicosis, or anything else. Then CBC, electrolyte B1, so rule out all of those things. Then starting with the thiamine supplementation, as we said, supplementation is more important than non-pharmacological and then pharmacological. So starting with the pharmacological, if the person might need to get hospitalization because she might has dehydration, so you are going to start with IV fluids and antiemetics, and then doxylamine, pyridoxine, dimenhydramine, and hydroxine, pyridoxine. So these are the things, metoclopramide, you can give ondansetron. So basically, in female, we prefer, in a pregnant female, we prefer ondansetron more than methylprednisolone in the first trimester. Just wanted to let you know because in the ondansetron, it can leads to the metoclopramide can leads towards the further episodes of vomiting, but ondansetron helps a lot. Avoid steroid in the T1 due to the increased risk of oral clefting. So you are not going to give the steroid. If swear, admit the patient, small meals, correct hypovolemia and electrolytes and ketosis, then TPN. Now, based on the scenario, you are going to see what they have given in the scenario. Because if they have given and keep on telling that the patient is feeling, drowsy and she keeps on falling down, she is having multiple episodes, she is unable to take even the water, then in this condition, you might need to admit the patient to the hospital. You cannot just write down you are going to start with a pyridoxine or giving the non-pharmacological condition because this person needs admission and maybe need IV fluids. So basing on their dehydration status, you are going to move on. Then complication, you are going to see the dehydration, Mallory with tear, because if the patient keep on doing vomiting, there might be some blood coming out. So Wernicke's encephalopathy, death, And IUGR is more common in the patient who is already doing the nausea and vomiting because the fetus is not getting enough meals. Now, in this subsequent prenatal visits, all you need to know is the visits. When are you going to do the first one, then second one, then third one? For uncomplicated pregnancies, SOGCs recommends every 4 to 6 week gestation until 30 week, and then 2 to 3 week from the 30 weeks. So that's what you need to know. The unsymphysis fundal height, all you need to know is when is the time of the umbilicus, 20 week. So below umbilicus, it's less than 20 week, and above umbilicus is more than 20 week. That's it. Then if this is less than dates, right, it could be AUGR. So always go with the common ones. It might be the date complication, like maybe the date is not fully calculated and there is no dating scan. IUGR, fetal demise, oligohydramnios, and then fetal in the early enlargement transverse lie. If there is more than dates, then data miscalculation, same thing. Multiple gestation, so there is more than one pregnancy, polyhydramnios, and large for the GA. That's it. Coming to the prenatal screening and diagnostic testing, all you need to know is what are the basic ones and what are you going to do in those ones. So testing should occur following counseling. So you are going to start with the counseling and informed consent from the patient. That's it. So if you can remember this high risk population screening test, you can. Otherwise, it's not that hard and fast rule that you need to remember. But this table 3 is more than important in anything else. Okay. So what happens is in pre-implantation, what are you going to do is you are going to do that pre-implantation genetic testing and mono, because if the person is coming to you and she wants, like, she's not able to get pregnant, what are you going to do? So this is a pre-implantation. So you will require IVF. So that's why you need to do all this pre-implantation genetic testing for aneuploidy, monogenic, and genetic testing for the structural rearrangement. That's it. Then coming to 8 to 12 week, definitely we're going to start with the dating scan, pap smear. Why? Because if they can ask you that a female is coming to you at 8 to 12 week, what are the further testing you would like to do in this person, right? In the CDM question, they can ask you to write it down. In the MCQs, they give you certain options and ask you to choose. So that's why you need to know what are the basic things. It's basically ultrasound, pap smear, all the infections like chlamydia, gonorrhea, urine culture insensitivity, HIV, VDR. So all the STIs you are going to rule out in the 8 to 12 week, because if there, then they can lead toward, because organogenesis is happening, so they can lead toward the preterm labor and can lead towards the further complications. So varicella, IgG, CBC, and the blood screening. So as you can see in the 8 to 12 week, we do the basic ones. Now more than 10, what are you going to do is NIPT, and in 10 to 12 weeks you need to do is CVT. But here I would suggest you to know this one as well. The diagnostic test is CVS. They can ask you, a person is coming to a female is coming to you at the gestational week of 12, or maybe they can ask you a gestational week of 14. She's coming to you, what is the diagnostic test you are going to do? So they're not asking you to write on NIPT, CVS, FETS, and anti-ultrasound, like nuchal translucency ultrasound. They're asking you a diagnostic test. So if you don't know CVS is a diagnostic test, you will not able to choose from MCQs. So diagnostic test, if they're clearly asking you at the gestational age of 14 week, what are the diagnostic tests? Even at up to 14 week, the diagnostic test is CVS. After 14 week, the diagnostic test is amniocentesis. So if you could remember this one, this is important. Okay. So if they ask you at the gestation age of 14 week, the diagnostic test, what is the diagnostic test you would do? Not the screening one. The diagnostic test is CVS and the amniocentesis. These are the two ones. Up to 14 week, we do CVS. After 14 week, we do amniocentesis for the diagnostic testing. Now coming to the 11 to 14 week FTS and nuchal translucency ultrasound. These are the measures like you do nuchal translucency ultrasound, beta HCG, PAPP, and then placental growth factor and MSA. But these are the screening testing. Only the diagnostic test is CVS and amniocentesis. So just remember these ones. After 15 to 20 week IPS part 2, what are those ones? MSA, alpha fetoprotein, beta HCG, unconjugated estrogen, and inhibin A. So if you could remember these ones. Then maternal serum screening. What are the testing you are going to do in the maternal screening, maternal serum screening? These ones are MSA, alpha fetoprotein, beta HCG, unconjugated estrogen, and inhibin A. The same one as IPS part 2. Then diagnosis, differential diagnosis of increased MS maternal serum alpha fetoprotein. There might be incorrect gestational age or one more than one fetus. As always, remember the common ones. So miscalculation, there is twins or the fetal loss or the oral open neural tube defect or the abdominal wall defect. So these are the common ones where the alpha fetoprotein is increased in the maternal serum. Then routine trimester 2 ultrasound at 18 to 20 weeks helps to determine the number of fetus. Like if you go for ultrasound, you can see if there is more than one fetus, then gestational age, location of placenta, and then fetal abnormalities. But if the location of the placenta is like, in the like in a certain position where you think this should not be there, like having placenta previa or something like that, it's not like you're going to start the treatment, because in the trimester 2, it's just the location of placenta for your own safety, so you can keep on repeating it and find out, because the location of the placenta might keep on changing. And by the time of third trimester, it reached to the normal position. So in this certain type at the T2 trimester, you find out if the location of the placenta is not normal. What you can do is you can advise that person to come back and maybe do the reassurance and ask them to avoid all those certain activities can lead towards the bleeding. So the location of placenta is just to let you know that this was there, and now in the next visit where it is, just for your own easiness. You're not going to start the treatment if the location of the placenta is abnormal. Okay. Then 8 to 12, 20 week, you're going to do the ultrasound for the fetal size. So they can ask you when is the time you're going to do the fetal size ultrasound. So it's an 18 to 20 week anatomy assessment and the placenta location. So they can even ask you what is the ultrasound to do, or at which gestational age the ultrasound for the placenta location is done. So these things are important. Then 24 to 48, 28 week, you are going to do the diabetic screening. It's important. And 28 week, you are going to do the repeat CBC and the ferritin and then ROGAM. They can ask you when are you going to check for the RHIG at the 28 week. 35 to 37 week, you are going to do the GBS screening, because this is the time when she is about to give birth. Then 6 week postpartum, you're going to talk about the depression, breastfeeding, mental health, breast exam, and all of those things. So as we are family physician, we need to know these screening, because we usually do these ones in our normal clinic. So if somebody is coming to you and she's not going to gynecologist, definitely we're going to refer that person to an obstetrician and advise her to have a follow-up with her. But at the same time, if she's just want to rely on us and want to do the screening on our level, so we need to remember these ones. So far as a family physician, we need to know these ones. That's why this table 3 is important. Please remember this one. Then coming to the ultrasound at 8 to 12 weeks, you are going to do the dating scan. Then 11 to 14 weeks ultrasound for the knuckle translucency, and 18 to 20 weeks, you are going to do the growth and anatomy ultrasound along with the placental location. Non-invasive prenatal screening, this is requires for the dating ultrasound for the accuracy. That's what you need to do. The advantages are increased accuracy. It's very like accurate more than anything else. And after that, you might need to do CVS as a diagnostic testing, or maybe amniocentesis for the diagnostic testing, as they have said, where the parents are potentially have CVS at 11, 10 to 12 week. And for the diagnosis over the 15 week, you are going to do amniocentesis. So that's why they might need to go. Let's suppose if they have find out in the NIPT that there is some abnormality, so you can suggest that there is a diagnostic testing, you can go further with that, right? But if this is pretty much accurate and they are okay with it and wants to go further management only on basis of this one, you can go with that. But if you can still offer them, there is some diagnostic testing like CVS and amniocentesis, if they still want to go with that, okay? Then the disadvantages, this does not screen for open neural tube defects and not covered by most provincial health insurance, so they have to pay them by self. So it's kind of important where they ask for the financial coverage, if they can cover it, or if you need to ask them to take the government help for their screening. So in this one, not covered by the most provincial health insurance system. Need to confirm with the invasive testing, which one, CVS and amniocentesis, they both are invasive, so it can lead towards the uh, uh, abortion. It can lead towards the abortion because these are invasive ones. So this is just a screening test, NIPT, and not a diagnostic test. So just remember this one. Now comparison FTS, MMS, and IPS. If you could remember it, well and good. If you couldn't, still it's well and good. The IPS 11 to 14 week, gestation age, ultrasound knuckle translucency 11 to 14 week, FTS blood, and 15 to 20 week MMS, MSS blood screening, including the inhibin. That's what you are going to do in IPS. Now, this is the diagnostic test. Which one are those ones? Amniocentesis and CVS, as we already discussed one. Indications age more than 35, because if you find this person is already at certain age where she can have the like chromosomal abnormalities, so you need to do these diagnostic testing. Risk factors, abnormal ultrasound or prenatal screening like IPT, IPS, FTS, MMS, and NIPT. Past history having genetic diseases or consanguinity more than 3 cause spontaneous abortions. Amniocentesis, definitely it's an advantage over the CVS because it's more accurate genetic testing than CVS. Then chronic villus sampling, it's like enables pregnancy to be, because in this how CVS is better than amniocentesis, because you can find out a certain type of diseases earlier in the stage, because amniocentesis is done after 15 weeks. So CVS is better in that way. But if you go by accuracy, amniocentesis is better than CVS. So these are the two major differences between CVS and amniocentesis. Otherwise, both are diagnostic testing. Now coming to the immunization screening, immunization antibodies produced against a specific RBC antigen. So investigation, this is important. What are you going to do is basically Coombs test. Screening is basically started with the Coombs test at the first visit for the blood group and then RH status and then antibodies. So you are going to start with the Coombs test. Then Clear-Betke test used to determine the external of the fetal-maternal hemorrhage. So you are going to do that one. Then ultrasound for the fetal high drops, and then middle cerebral artery Doppler are done to assess the degree of the fetal anemia if you need it. If not available, then you can just go with the bilirubin. That's it. It's not like hard and fast rule. All you need to start with the Coombs test, Clear-Betke test, and go with the ultrasound for the fetal high drops. Otherwise, if they ask for certainly fetal anemia, then you go for the middle cerebral artery Doppler. Then chordocentesis for the fetal HB should be used cautionary, like it's not a first line because it's an invasive one. Standard dose of this is kind of important, because if they ask for sufficient dose is given or not, like in Canada QBank, they give this kind of stupid question, so you never know, they might ask you in the exam as well. Standard dose of 300 pg of the Rogam sufficient for 30 ml of the fetal blood. Give additional 10 pg of the Rogam for every ml of the fetal blood over 30 ml. Just remember it as it is. Then you are going to give the exogenous. Prophylaxis is giving exogenous Rogam IgG, binds to RH antibodies and fetal cells to prevent them from contacting with the maternal, so leading towards the hemorrhage. So Rogam you are going to give at routinely at 28. So this is important. When are you going to give the Rogam? So usually we give at 28 week, within 72 hours after the birth, and within it's an invasive procedure in the pregnancy after diagnosing the CVS and amniocentesis. If CVS and amniocentesis is done, then you are going to give the Rogam as well. So they can ask you that the diagnostic test is done. What is the one more thing that you would like to do in this case? So what is that thing is basically giving the Rogam. So after CVS and amniocentesis or any other invasive procedure, you are going to give the Rogam. As a part of management of ectopic pregnancy with the miscarriage or therapeutic abortion with an antepartum hemorrhage and with the trauma, Rogam 300 pg provides the sufficient prophylaxis for the 30 ml. And a Clear-Betke test is used to test if the Rogam is enough or not, or if the additional Rogam is needed or not. So if they can ask you if you have given Rogam, how can you find out if further Rogam is needed or not? So the test is called Clear-Betke test. RH negative and the AB screen positive, follow mother with the serial monthly AB titers throughout the pregnancy. Ultrasound, the serial amniocentesis may be needed. And after amniocentesis and CVS, you need to give the Rogam. Starting with the treatment, let's suppose like the failing biliary pigmentation warrants no intervention because it's kind of feeling like it's getting better, so you don't need to do anything. Intrauterine transfusion between 18 to 35 week gestation of O negative packed RBCs may be required, because at this point they have already developed at the stage where the rogam, more than rogam, there is a blood transfusion that is needed. So severely affected fetus, because if there is anemia going on, so you need to give the transfusion. Early delivery of the fetus for the exchange transfusion of 35 weeks. Complication, what complications? Fetal hydrops is one of the most common complications that can develop. What happen is edema in at least more than 2 fetal compartments due to fetal heart failure. So that's why, just like CHF, chronic heart failure, so that's why it can happen. So it's like fetal RBCs hemolysis leading to fetal anemia, CHF, edema and ascites, and fetal hydrops. So these are the 4 basic complications, or the erythroblastosis fetalis. So just remember these ones. What are the complications that can develop in the immunization screening? Then fetal surveillance, NST, like non-stress testing. These ones here, the baseline, variability, deceleration, acceleration, and interpret clinically. So these ones, so the basic ones, the normal tracing is important, because if you don't know the normal one, how are you going to find out the abnormal one? So the normal one in the category 110 to 160 is baseline. So if less than that, it's deceleration. If more than that, it's acceleration, variability. If there is a 6 to 25 BPM, it's normal. But if it's more than less than, like, for more less than 40 minutes, and it means it's absence or minimal. Then interpret clinically depending on the fetal compromise. If the fetal is not breathing properly, so those ones. Atypical tracing and then abnormal tracing. Atypical is basically it happens because of like uncomplicated, the position is different, mother is dehydrated, so physiological response. Atypical is something like that. She might be feeling like, taking any medication, or she was drowsy, that's why the baby is drowsy as well, or any certain type of anything. So that's atypical. But knowing the abnormal one, when is abnormal? Like atypical, you need to know the normal one and abnormal one. Atypical is something that's between those two. So if you know the normal one and abnormal one, you are good to go. So bradycardia is less than 100, tachycardia is more than 160 for more than 80 minutes, and then erratic baseline. So less than 5 or more than, for more than 80 minutes, it's kind of abnormal. More than 25 for more than 10 minutes, and this is sinusoidal. Repetitive complicative barrier. So you did doing, keep on checking the keep checking multiple times, still it's keep on showing the deceleration, it means this is abnormal. So recurrent late deceleration or single prolonged deceleration, usually absent, or if present, do not change classification of the tracing, then there is positive fetal compromise that's happening. So the normal NST2 a deceleration is more than 15 minutes from the baseline, lasting from more than 15 in 20 seconds. So having that certain type is totally normal. So describing NST baseline, absent or minimal, moderate, marked variability, so on the base of that. Acceleration, present or not present. Deceleration, early, late or variable. So reassuring BPP, LAMP, limb extension, amniotic fluid index, moderate and breathing. We will just. So here BPP is basically tone, movement, breathing, amniotic fluid index. So what happened is tone, at least one episode of limb extension. Movement, 3 discrete movements should be there. Breathing, at least one episode of breathing lasting for at least 30 seconds. And then amniotic fluid pockets for 2 into 2 is basically normal. So these are the reassuring one. So you need to know the certain, what are the parameters of BPP? What are those 4 parameters? So in CDM, they can ask you to write down the 4 parameters of the BPP, or in MCQs, they can ask you to choose from the options, what are the 4 parameters, or they can give you the, if the female or the BPP shows that there is one episode lasting for 30 seconds, is it normal, or what are you going to do next? If this is normal, then you are going to do the reassurance. Just that it is. That's why you need to know this table 6 ultrasound scoring component of the BPP. Then operating characteristics, interpretation, if normal more than 32 week gestational age, what happened is 2 acceleration. Why I'm saying this? Because normal, you need to know the normal one. If this is normal, then all you need to do is reassurance. If not, then you might need to refer that person to the obstetrician for further consultation. At least 2 acceleration of fetal heart rate more than 15, and in the normal less than 32 week, at least 2 acceleration of heart rate more than 30 for more than 10 bpm, abnormal less than 2 acceleration. So as they said, at least 2 acceleration should be present in 20 minutes. If this is less than 2 deceleration in 40 minutes, it means it abnormal. If not observe acceleration or the fetal movement in the first 20 minutes, stimulate the fetus by asking the change the position or asking or make the movement and continue monitoring for the 30 minutes. So it means if you did the monitoring for first 20 minutes and you find there is no movement or there is no acceleration, it doesn't mean that you are going to make the diagnosis. You might need to change it, stimulate the fetus. So the next thing is stimulate the fetus, not just doing something else. So stimulate the fetus for the and then keep monitoring for the 30 minutes. So it means you are going to keep monitoring until you are sure that this baby or this fetus is having the problem. So the BPP, what are the indications? When are you going to do the BPP? Otherwise, we don't do in everyone. Post-term pregnancy, decreased fetal movement. I usually, like a female is coming to you that my baby is not moving from since last night. You are going to do the BPP. Interpretation 8 to 10 is basically normal, or 10 to 10 is normal. 6 to 8 is basically prenatal mortality, or maybe there is some certain type of maybe fetus is sleeping, or maybe there is some fetal maturity disturbance, or even the age miscalculation could be there. 6 to 10 is basically prenatal mortality or equivocal test, repeat BPT in PPP in 24 hours. So they can ask what is the next thing you are going to do in the 6 to 10 with the BPP. So you are going to repeat it. Okay. And if 0 to 4, then obviously consider delivery for the fetal indication. Depends on the fetal indication. Starting with the counseling, you are going to start with the nutrition counseling, asking them what they need to eat and what they does not need to eat. So remember this one, caloric increase. In T1, it's 100. In T2, it's 300. In T2 and T3, it's 300. And in the time of lactation, it's 450. So just remember this one. Nutrition, you are going to ask the folate. So 0.4 to 1, starting 2 to 3 month post preconception and 4 to 6 month in postpartum. 4 mg in the neural tube defect. If you think this person is like having a after certain type of age, like maybe 35 years or those things, where they have already been diagnosed with NTD in the previous pregnancy. So in this one, you are going to give the 4 mg. 4 to 6 weeks, you are going to give the check for the blood volume and ask them to eat rich food with the folic, spinach, lentils, and all those. Calcium 1200 to 1500, vitamin D is 1000, and iron is 0.8, as they already told you. Then fatty acid, caffeine intake should be decreased to 300. So you need to know, because they can ask you if the female is already taking the coffee and those things. So what are you going to counsel about that one? So just knowing that basic counseling. Herbal teas and preparation, that's definitely she can take herbal in the moderation like 2 to 3 cups. Food-borne diseases, you can just tell them not to eat the contaminated one or the raw food. Chemical contamination, and the certain guidelines for the mercury 0.5 ppm in the fish is not considered harmful. So if somebody is living in the certain type of area where they need to